I'm now going to introduce Dorella Franchi. Please, slightly out of order, so I apologise for that. As Anne Kusterman said, Dorella is going to cover other biomarkers, in particular HE4 and ROMA. I don't know if anybody works in private practice, but certainly in London, about every 5 minutes, I get a piece of paper shoved through my door telling me I should do ROMA tests at the doctor's laboratory, whatever it is, private lab. I always think that's rather entertaining, but I'm not sure the data really sort of supports doing that. So Dorella is going to give us the lowdown on the role of HE4 and ROMA and its contribution to ovarian cancer diagnosis. Thank you very much.
Morning, everybody. Thank you very much. The topic I was asked to talk about is HE4 and ROMA. Do they add anything in the diagnosis of ovarian tumor, and should we be using them? We know that a pelvic mass is diagnosed about in 10–20% of women during their lifetime, but a very small proportion of this will prove to be malignant. But anyway, it's really very important to evaluate the risk of malignancy of a pelvic mass in order to triage the patients to the most appropriate treatment in a specialized center in order to increase their overall survival and to have a better outcome. So what's the best method to triage patients to the right place of care? During this year, we have seen the development of new biomarkers, and one which is now available in our daily clinical practice is HE4. This is a glycoprotein originally identified in a distal human epididymis. Its function is not really very well known. Probably it has a function in the sperm maturation, but it was also found expressed in respiratory tract, in the nasopharynx, kidney, reproductive tracts of both genders, except from ovaries. The cutoff value that have been proposed are 70 picomole liter for premenopausal patients and 140 picomole liter for postmenopausal patients, but there are some factors that can influence the level of HE4, such as age, smoke, postmenopausal status, renal failure, and it has seen that it is overexpressed in some cancers, such as epithelial ovarian cancer, endometrial cancer, lung cancer, and transitional cell carcinomas. This is the first paper that was published in 2003 that compared HE4 to CA125 in a very small number of patients, but they concluded that HE4 is a potentially useful biomarker for ovarian cancer, and the results indicates also that it was better than CA125 in distinguishing patients with malignant disease from those with benign ovarian disease. And again, it was shown in this paper where they compared pre- and postmenopausal patients, healthy patients, benign, cyst, endometriosis, and ovarian cancer. CA125 was compared to HE4, and they saw that CA125 is more sensitive, while HE4 is more specific. And also the same group demonstrated that HE4 may be more sensitive than CA125 in early stage ovarian cancer. So this could be an interesting marker because it has a sensitivity which is rather comparable to that of CA125, but it's more specific, especially in premenopausal patients. It is not increasing endometriosis, and it's elevated probably in more than 50% of ovarian cancer that usually do not express CA125. And today there are a lot of data available, especially in combination with the CA125 in the diagnosis of pelvic masses. This is a quite recent meta-analysis that included 45 studies to evaluate the accuracy of HE4 in identification of ovarian cancer, but we can see that there is a wide variety in terms of sensitivity, a little less in terms of specificity. All the results were included in this ROC curve, and the overall area under the curve was 0.91, which was quite good, but the overall sensitivity for other studies was 0.78 and specificity of 0.86. HE4 showed to be a little more sensitive in postmenopausal patients than in premenopausal patients with the same specificity, and again, more sensitive in late ovarian cancer than in early ovarian cancer. but it has also different values according also to the method which is used to dose the HE4. So in this meta-analysis, they concluded that it has a great heterogeneity in terms of sensitivity and specificity that was found, and probably this is due to different detection method, to different cutoff point, different study design, inclusion or not of borderline tumors, different menstrual stages. But anyway, the hypothesis is supported that HE4 level can be an important biomarker in the diagnosis of ovarian cancer. In 2008, Moore published this paper where they tried to verify the accuracy of some or different biomarkers and the addition of these biomarkers to CA125 to HE4, the addition of HE4 to CA125, and the addition of one more biomarker of those that verified. But what they found that only the dual association of CA125 and HE4 at predefined specificity had a better sensitivity than HE4 alone or CA125 alone. So they concluded that in stage 1 disease, at the specificity of 90%, HE4 has a better sensitivity than CA125, and that the combination of both shows the high sensitivity relative to any other dual combination of biomarker, and adding other biomarkers to the dual combination led to only limited incremental of value of sensitivity. The following year, they validated this prospective trial on a new model, this mathematical model. They developed this algorithm that was named ROMA, which means risk of ovarian malignancy algorithm that included CA125, HE4, and menopausal status. The aim of this study was to categorize women with a pelvic mass into low risk and high risk for epithelial ovarian cancer. And assuming that 20% of women with an ovarian mass was found to have an epithelial ovarian cancer, the sample size for this study had to be more or less 500 patients to find at least 100 patients with ovarian cancer. This is the ROMA calculation, which has two different algorithms for pre- and post-menopausal patients, and those are the cutoff levels that they used and proposed that are different for pre- and post-menopausal patients. For premenopausal is 7.4% for to distinguish between high risk and low risk, and postmenopausal 25.3%. And what they observed, they enrolled 530 patients, including 129 epithelial ovarian cancer. They obtained a sensitivity of 88.7 and a specificity of 74.7, with a negative predictive value of almost 94% and a positive predictive value of 60%. Of the 17 patients that were misclassified, that were included in the low-risk group but were borderline or invasive ovarian cancer, what they observed was that, I'm sorry, but there is a little piece lagging, which is under there. Oh, that's Well, okay, 9 patients were borderline tumors, while only 8 patients were invasive ovarian cancer, and the 6% of all the patients was really misclassified. This is not evident. Sorry.
Excellent.
Okay, this is good. So they concluded that of the patients that were diagnosed with an invasive cancer, the 94% was correctly assigned and triaged for the best treatment in specialized centers, and the 75% of the patients with a benign disease could stay in their community hospital for the surgical care. So they concluded that ROMA was easy to be implemented and used, was objective because independent on the sonographer experience, it indicates a risk of malignancy. It intended to be used as a triage tool and not as a screening tool, but it needs to be validated. It's very recent, this review that was published 2 months ago, more or less, on ROMA. They included 14 studies, and the problem was that among all the studies there were different cutoff levels, of course, and different way of measuring HE4. But what they have seen was that there is a big variability in terms of sensitivity and specificity for all the patients, for premenopausal and postmenopausal patients. Here you can see the ranges in terms of sensitivity and of specificity, which are really very wide. But anyway, they concluded that ROMA is characterized by the high accuracy and repeatability in stratifying patients into low risk and high risk for ovarian cancer. And ROMA has an advantage, which is to reduce the unnecessary or excessively radical surgery. But what I agree is that ROMA is reproducible in the hands of young and experienced doctors, physicians with little experience in the field of diagnostic ultrasonography, or doctors who work in hospital with a lower referral base. But anyway, it's likely that ROMA sensitivity and specificity can be further improved by including other factors such as age or ultrasound findings. And probably larger studies are needed to demonstrate this. And there are also conflicting results, because some authors are favorable to ROMA, some others are not, because some studies reported that the addition of HE4 to ROMA does not offer improvement upon CA125, that ROMA is effective more in postmenopausal patients than in premenopausal patients, that sometimes HE4 alone outperforms compared to ROMA. But anyway, the problem is that there is a very big variability in the composition of target population, in types of cancer diagnosis, different cutoff levels, and different use of assays. In 2010, for the first time, these biomarkers were compared to a model that included ultrasound findings, imaging findings, and they compared RMI to ROMA to predict epithelial ovarian cancer in patients with a pelvic mass. And what they obtained, what they found, was that ROMA was superior to RMI in terms of sensitivity, in terms of positive predictive value, negative predictive value, has an overall agreement in all groups. They compared all benign patients with ovarian cancer without borderline, with early stage, with late stage, but in all groups, ROMA seemed to perform better than RMI. And also in terms of area under the curve, again, ROMA was significantly better than RMI. So they concluded that the dual marker, the ROMA, was better than RMI in identifying epithelial ovarian cancer in patients with a pelvic mass, and that ROMA provides more objective and reproducible results between different centers. But a little later, this Danish group published this paper on 1,200 patients with more than 200 ovarian cancer, and they wanted to evaluate the accuracy of HE4 and ROMA compared to CA125 and RMI in differentiated ovarian cancer from other pelvic masses. And what they found that RMI, in terms of specificity at predefined sensitivity, was superior to ROMA, and both were superior to the single biomarkers. And in terms of sensitivity at predefined specificity of 75%, again, RMI was similar to ROMA, but both of them were superior to HE4 and CA125. But in terms of accuracy and the area under the curve of ROMA and RMI were comparable. Both were superior to CA125 and HE4, and both of them were comparable each other. So they concluded that HE4 performed equivalent to CA125 in stratifying women with a pelvic mass, that ROMA is valuable as first-line marker for referring high-risk patients to a tertiary care center, that ROMA is as good as other ultrasound-dependent RMI in differentiated pelvic masses, but then they need anyway a further improvement, especially for premenopausal patients. The same year, the group of Leuven published this paper on 432 patients. Again, they compared the ROMA to RMI, but they found different results comparing it to subjective assessment. And they found that subjective assessment was superior to RMI, and this was superior to ROMA in all the patients that were observed, and by dividing them in premenopausal and postmenopausal patients. So they concluded that although new tumor markers model are promising, they do not contribute significantly to the diagnosis of ovarian cancer, and still subjective assessment is superior to any other model in discriminating benign versus malignant masses. And again, ROMA was compared also by the group of Love and here on Kaiser to logistic regression model 2. And we can see that for all the categories, for all the patients, pre- and postmenopausal patients, LR2 is superior to RMI. And also in terms of area under the curve, this LR2 is superior to ROMA, in all malignant disease, and especially in both in borderline tumor and in early stage. So they concluded that LR2 shows a better diagnostic performance than ROMA in the characterization of pelvic masses, both in pre- and postmenopausal women, that LR2 missed fewer borderline tumor and early stage invasive cancer rather than ROMA, and this finding suggests that HE4 and CA125 may not play an important role in the diagnosis of ovarian cancer if good ultrasonography is available. And to give a final answer to the initial question, so are serum, HE4 and ROMA score useful to experienced examiner for improving the characterization of adnexal masses? There is another very interesting paper published by the group of Loben, where Kaiser and co-worker performed this prospective trial in a tertiary care hospital, and all ultrasound were performed by level 3 examiners. They enrolled 360 patients. The 60% had benign disease, the 40% had malignant disease. Those are the algorithm that I used and the cutoff level for ROMA that I used. And according to the subjective assessment, they divided all the pelvic masses according also to the level of confidence. The 54% were assigned to the level of certain, certainly benign or certainly malignant group. In the 37% of the cases, the examiners were probably certain of the diagnosis. Only in the 8% of the cases, the examiner were uncertain about how to classify the masses, and especially fibromas and borderline tumors were overrepresented among tumors that were where the examiners were less confident. But again, comparing subjective assessment, which is the ROC points, to HE4 and ROMA, subjective assessment was always superior to HE4 and ROMA in all the three groups, and especially in the group where the examiners were uncertain, HE4 and ROMA didn't add anything to the subjective opinion. So here is represented the ROC curve for all three groups, and again we can see the subjective assessment has an area under the curve of 0.97, ROMA 0.89, and HE4 0.85. So they concluded that the measurement of HE4 or ROMA do not seem to be useful in classifying adnexal masses after subjective assessment by an expert examiner with transvaginal ultrasound. And the conclusion that I share is that authors feel that it should be possible for most examiners to equal or even to exceed the current performance of biomarkers with the use of YOT models and rules. And again, we must go on to invest in education and training gynecological ultrasound until maybe more promising biomarker become available. Thank you very much.
Thank you, Dorella. Any comments from the gentleman at the front who seemed to be quoted a lot during the talks? No? No comments? No. I just wondered, because I mean, we've asked you to talk. Is it unfair to ask you about over one? Do you have a view on over one? We were in the States recently, and they seem, well, it's been licensed in the States to use over one, I think, as a test.
I don't have a personal.
So you have no personal view on that. I don't know if Toon might comment on that. So Toon's going to talk over once, that's fine. I think that's quite important because certainly in the States they're looking at it pretty seriously as what does he have a view on over 1? As over 1 as a marker of ovarian cancer?
It's an association of biomarkers.
Yeah, but the answer was no. Okay? Anything else? No, I think that's Dorella, thank you.